Susan, hi. Thank you for coming to the British Trauma Society meeting and giving a keynote on the role of imaging in immediate life and limb-threatening injuries. So you're based at the Royal London,
Yes, I am. Yes.
and how long have you been there?
Since about 2005, I started as a trainee and never left, actually, because I loved it that much.
Amazing,
Yeah,
amazing. So you do a lot of trauma scanning.
Yes, we do indeed, yeah.
Brilliant. What do you
Busiest.
think, or what's your impression of the British Trauma Society conference in conjunction with the Scottish Trauma Network? This is the first time we've been here in 30 years.
I think it's been really lovely to come and see so many different people outside of medicine. We're just so used to, as a radiologist, I'm really used to talking to radiologists and trying to impart learning to them. But to actually get back from all these, I've talked, even in the breaks, I've talked to people from STAG, I think, which is our equivalent to TARN, and, orthopaedic registrars, consultants, ED physicians. It's been super cool to just actually have that. And it's very, that collaborative thing, it kind of matches what we do at the Royal London as well. We've got that kind of very collaborative approach in terms of, good interactions and relationships between ED colleagues, or orthopaedic colleagues, trauma surgeons. They're just the best.
We've got lots of ways of capturing data, and what I want to know is, what are your thoughts on the way we currently capture data for trauma patients, and where do you see the future of it being?
I think capturing the data is really important to allow us to even just to benchmark against other major trauma centres. You have to have some kind of objective KPIs, to work against. Otherwise,
it's a Wild West, isn't it?
Well, it is actually, and also, and if we all do it, and I think, but key is actually having the resource to properly document and get that data. So having the ability to have the financial, ability to get the right people in, trained people to do the job, because obviously TARN auditors and collectors are actually not medically trained. So I'm often getting emails asking, what is this liver injury? What does this mean? Is it, what grade is it? And in terms of AST, so actually a lot of it is about, it's great to have data, but you need accurate data and represent actually what you do, because I think if we don't get our KPIs accurately recorded, then it isn't. That's where it will fall down.
Absolutely. And I know we already spoke that you don't use the trauma app. And neither do I.
Yeah, I'm going to go and have a chat with the guy
neither do I
now.
currently.
Yeah.
But one of the beauties that I've seen that it does is obviously is that live data capture.
Yeah.
You're getting it at point of care. And in fact, Rob Bentley was on here earlier, told us that they've introduced it, or they're planning to introduce this sort of data capture side of things.
Yeah, saw that, yeah.
I don't know if it's with this app or not, but bring it into pre-hospital.
Yeah.
So there's a seamless transition where what the guys are doing and seeing it seen, they're recording live, that we've done this, or this is the observations, this is the injury, videos, conversations.
Which would be brilliant from a learning perspective.
Absolutely, and that feeds through, so the ED teams have got it seamless, so that will transition into the electronic
continuity
record.
Of care. Yeah.
Continuity of care, continuity of record keeping.
Yeah.
And so you can actually then start to really see real-time analysis of what's the patient's journey, and each intervention, and
has
which
it
will
made a
then
difference? Has it not? Yeah.
Exactly. Yeah, absolutely.
Highlighting.
Are we are what we're doing worth doing? So I think that's super important, and I think that's that prospective data capture. As a registrar, we had to go back and audit TARN data, and then found all the gaps. And you can't work out why somebody asked for it, when they asked for it, when the chest drain was actually done, isn't recorded.
Yeah.
So you suddenly start thinking, well, was it in the first half an hour? Was it when they went to the ward, etc.? They go with the chest drain. You look at it on the. I remember looking at X-rays and CTs to try and work out at what point the chest drain appeared.
Oh, yeah.
But sometimes the X-ray can be taken 1 hour later.
Yeah.
So you have no idea when it went in. It's having that prospective live data capture, I think, is a game changer.
Very, very helpful. Yeah.
So I'm going to ask you a question about you. What's one of the most important changes you've seen in trauma care in your career?
I think, the ability to do CT so rapidly. I'm biased because I am a radiologist.
You're allowed to be biased.
But I do remember actually when CT, if you needed a CT in trauma, they'd request it, and you could actually go and have dinner and then come back and it'd still be
absolutely.
processing.
I remember that as well.
So, and actually now it's, we've got a wealth of it. Actually, and it's interesting because then when you've got so much imaging, sometimes you can get, as I said in my talk, you get lost in a sea of
5,000,
imaging.
6,000
and actually
pictures.
you can lose sight of those, the key golden hour stuff that we're trying to elicit, And then there's also, I suppose, moving outside of the acute emergent bit of it, the face of trauma is definitely changing in terms of rehab. And we've seen that in your lectures, actually, with that, the volume of input required for everything. And even from an imaging perspective, we see that, the imaging doesn't just stop at the front door. We find patients, through, they can be in for a month, 2 months.
Absolutely.
Like the
Repeat
crush injuries,
scans,
the bowel
MRIs,
injuries,
and so on and so on.
massive injuries, and it's it can be quite a rough road from them, and multiple scans, multiple interventions. So there's a lot to be said for thinking about all that rehab and the aftercare. Well, the in hospital and then discharge from hospital. What does that look like? I mean, our place has a great after trauma care service, which has been set up a couple of years back, and it's got a great team of nurses who basically link in.
Absolutely. The journey's long, isn't it, after major trauma?
Absolutely, yeah.
Is AI going to put radiologists out of work?
Do you know what? I don't think so. And I mean, I don't think in my lifetime or in my career, but I think it'll aid us for sure. I would say where there's binary decisions to be made, like, the fast positive or negative, I think we'll get something that'll work for that. CT heads, blood, no blood, bleeding, non-bleeding, that definitely will be useful. And it will help, I think it'll definitely prioritise, scans in terms of for reporting, flag the things that need urgent triage if they're not already clinically presenting urgently. It might rib fracture detection, those flail chests, which are a nightmare to report. But I reckon, there's already stuff out there to try to potentially evaluate.
So you think
that.
currently it's more of a safety net sort of?
Yeah,
plan?
and actually, is that a bad thing? I don't think so, because actually we're all, nobody's, we're not. We make mistakes, And
so you don't think diagnostic radiologists should all retrain as interventional radiologists?
I don't think so. I think we've still got a job. I think I'll be all right. Well, I hope it will. Yeah.
Getting on to jobs. Mm-hmm. Okay. Is medicine still a worthwhile career? And if so, why?
I think it is. Again, with the right support and the right training and adequate training programs. I feel really disheartened seeing, juniors. We do these days where we try to encourage them into our specialties. And a lot of them, more and more, they're all heading off to Australia and New Zealand, and we have to ask ourselves, why are they doing that? Because actually, I think, you get no better feeling of when you actually make a difference to a patient. It's really wonderful. But, also what isn't wonderful is seeing the juniors under immense strain in terms of way too few of them on a shift, so and understaffed and not trained adequately, or feeling undertrained or under-resourced. I think I love my job, so and I love the fact that I've got that collaboration with so many different specialties in radiology. I think that's one real massive plus with radiology. You get to talk to so many different, orthopods, trauma surgeons, ED.
What critical data do you think that we're not capturing currently that would make a real difference to patients from a radiology perspective?
Gosh. In terms of...
I suppose incidental findings. We see a lot of what we call incidental omas on scans.
Yeah, we do.
There you go.
Flagging,
bone
being
density on CT or MRI? Or?
Well, bone density, that actually, to be fair, that is a good one. The bone density thing, in terms of if we could utilise on our CT old lady scans, essentially our silver trauma, and if we could clearly delineate that there's osteoporosis, to sensitivity that's equivalent to what our gold standard, which is what DEXA is.
DEXA,
and flagging that up, and not only flagging up getting it flagged and flagged to the appropriate referrer. But then on the other end of that, you still need the fracture liaison service, which can often be under-resourced and stuff like that as well. So we can have all of this. But even, and just flagging up,
We discussed in the medical legal course that we ran yesterday, this common thing that we sometimes see, which says, IRMA says the requesting clinician should report this. If you need a report, ring radiology. And that falls back to then an orthopedic surgeon looking at somebody's chest x-ray where we're looking for, say, rib fractures, and we've asked for a chest x-ray. And there was a case presented yesterday of a small little nodule in the corner that somebody missed, and 6 months later it was seen as a huge nodule, and it went from operative to non-operative outcome in 6 months for that patient, and that was obviously missed.
Honestly, I mean, we have these discussions as well, but the bottom line is, if a scan's been done, it needs a report. You know, whatever that report is it an AI generated report for a chest X-ray of nodule detection? Well,
where does the responsibility sit for that report?
Well, that is also a very good question. It's what levels we're expected to accept in terms of sensitivity, specificities for all of that AI detection. But ultimately, I feel like it'll have to be with a happy medium of the AI will detect, but it'll need a second review to correlate with it. And that's why I don't think we're going to be out of a job just yet. Could be wrong, but, you know, because ultimately, exactly what you're saying. No, because actually,
you will need it.
You know, the nodule might not be maybe a rib projection. Do you know what I mean? And you have to dismiss it. But equally, in that situation, there's always the horror stories, isn't there?
Absolutely. We were talking about this because, again, we've had reports, for instance, if an out-of-hospital radiologist does a report by any company, there's several of them out there, where does that responsibility sit for the report or the actioning of it, the administration? Apparently there's lots of claims coming in.
Oh, really? Okay.
Yeah, claims coming in. The lawyers were telling us yesterday where they're trying to unpick, because where does the delegate responsibility sit? Is it with the hospital who employed the company, who then employed a radiologist who's not on site? So it's an interesting conundrum at the moment. And
I'm not sure. That's so difficult because, I mean, imaging, we're never going to be able to stop people imaging patients, you know. So then
the demand's just going up and up and up.
Oh, yeah, no, they are. So we have to be able to outsource. That's the reality. And I don't think AI has the technology is there yet. There you go, to actually put a proper standard full report for scans, basically. So, and until such times like that, you know, we just have to be able to recognise that we're outsourcing to a company that I think is heavily governance. You know, there's a lot of governance around it, and it's all audited, all the reports. So, you know, yeah.
Hopefully that's enough of a safety net.
Yeah.
Most of the time.
Maybe, yeah.
Susan, thank you very much for coming and speaking to us and your insights into radiology and trauma.
Thanks for having me.
Thank you very much.
Cheers.